Giuseppe and I are doing a double act on hepatitis C. I'm going to set the scene with a brief presentation on the epidemiology, and then Giuseppe is going to do probably what will interest people more in terms of the new treatments. There's my disclosure. So in terms of global epidemiology, we know that HCV contributes substantially to the global disease burden. And it's estimated that there are between 130 and 170 million people who are HCV seropositive. This is a very broad estimate because surveillance is quite suboptimal on a global level. And when we think about chronic HCV, we need to take into account spontaneous clearance in about 20% of people and the impact of treatment. So it's estimated that more than 500,000 people die every year from HCV-associated causes worldwide, and that around a quarter of all cases of hepatocellular carcinoma and liver cirrhosis are due to Hep C. So the map here gives some data on HCV seroprevalence, and the areas in red are the highest prevalence regions and where there is prevalence exceeding 3.5%. So this slide shows HCV genotype distribution, and globally, genotype 1 predominates, accounting for nearly half of all HCV infections worldwide, followed by genotype 3 at 22%. Just a couple of points to make. Egypt, which has the world's worst HCV epidemic with a seroprevalence of about 14 to 15%, is almost entirely genotype 4, and genotypes 5 and 6 are mainly restricted to the Far East. So turning to children, it's quite tricky to work out the number of children that are HCV seropositive, but Manal El-Sayed and colleagues conducted a modelling exercise earlier this year, and they estimate that there are 13.2 million children worldwide who are HCV seropositive, and that there are 6.6 million viremic infections. The epidemiology of pediatric HCV is quite poorly defined, and this is partly reflective of the generally poor surveillance of hepatitis C globally. But we do recognize that there's a lot of under-ascertainment of HCV in children. And for example, in a recent US study, they estimated through some data linkage that only 1 in 7 children with hepatitis C are diagnosed. This compares to about half in the adult population in the States. And in a Scottish study, they estimated that 2/3 of children with HCV infection were undiagnosed. And again, in the UK, about half of adults are believed to be aware of their diagnosis. So in terms of where these children live, 85% of the 6.6 million viremic children are living in low and lower middle income countries. And more than half of all the infections in children are concentrated in just a few countries, in 7 countries, and they're shown, I don't know if I can manage that. Anyway, they're shown in red on the bottom slide. So globally, the estimated prevalence of pediatric viremic infections is 0.4%. Again, that comes from Manal El-Sayed's modelling exercise with a range of 0.1 to 0.8%. And I tried to summarize what data are available from various studies and surveys of HCV prevalence in children. And you can see that, for example, in North America, there are very low prevalences. But as you would expect, given the, what we know about Egypt being such a high burden country, there is much higher prevalence there, 2%. So in terms of hepatitis C, these are the main transmission routes, and with respect to children, mother-to-child transmission is the most important route of acquisition. But we also know that HCV is around 10 times more infectious by blood contact than HIV, and therefore both parenteral and iatrogenic transmission remains important for children. So I just wanted to say a little bit about unsafe healthcare injections. About 15 years ago, WHO undertook a large investigation into healthcare injections, and they estimated that 42% of HCV infections acquired in developing and transitional countries were the result of unsafe healthcare injections, and that around 2 million new HCV infections a year were being contributed by this. So since that time, huge efforts have gone into trying to reduce the number of unnecessary medical injections, and also to ensure that where injections do take place, that they're safe. And by 2010, the global reuse of injecting devices had declined from this 42% to around about 5%. But we have to remember that there are still countries in the world where unsafe injecting continues, and also that some children may have been infected prior to these improvements taking place. So sort of following on from that, we recognize that there are groups of children who are at increased risk of hepatitis C because of exposures in medical settings where there may be poor blood safety or unsafe injections or inadequate sterilization. And it's well recognized that childhood cancer survivors, those with transfusion-dependent hemoglobinopathies, and renal patients are at increased risk of hepatitis C. Although this is mainly historic and resource-rich settings, this is still ongoing in some less well-resourced countries. And HCV seroprevalence in children with transfusion-dependent thalassemia major ranges up to 76% in some Egyptian studies, 10% in Malaysia, 12.5% in Bangladesh. I wanted to say something about injecting drug use, not just because of adolescent injecting drug use, but also because for pregnant women with hepatitis C, injecting drug use is an important route of acquisition for them. This graph here just highlights how quickly an injecting drug user can become infected with hepatitis C. So it's estimated that half of people who inject drugs in developed countries and 80% of those in developing or transitional countries will have acquired HCV by 5 years after starting injecting drug use. And this difference really partly reflects the access to harm reduction. And I just wanted to say a little bit about Eastern Europe and Central Asia, which is a setting that I do quite a bit of research in. And this part of the world has injecting drug-driven HIV and HCV epidemics. It's recommended that for harm reduction to be successful, needle and syringe exchange programs should offer at least 200 syringes per year to each injecting drug user. But the regional average in Eastern Europe is about 50, and there's also no opioid substitution therapy in Russia. So as a result, this is results from a recent study in several cities in Russia, and we see that HIV-HCV co-infection rates there are 44%. So surveys of people who inject drugs usually demonstrate that a large proportion of them started injecting in adolescence. And we might imagine that young people who inject drugs are at increased risk of acquiring hepatitis C because they have poor access to harm reduction services. For example, in some countries there are age restrictions in terms of being able to access services. They are more likely to share injecting equipment, and they also tend to have less knowledge of safer injecting practices. And within that group, there are specific groups who are at incredibly high risk, and that includes street children, such as the children shown here, who are street children in Odessa in Ukraine. So, as I said, vertical transmission is the most important mode of acquisition for children, and as is seen for HIV, most of this transmission occurs around about the time of delivery. There was a meta-analysis conducted recently to investigate rates of mother-to-child transmission of hepatitis C, showing that the risk is about 6% in HIV-negative mothers, but nearly twice that in HIV-positive mothers. High hepatitis C viral load is a risk factor, but so far maternal genotype, mode of delivery and breastfeeding haven't been shown to be associated. So when we think about vertical transmission of co-infection of HIV and HCV, obviously both viruses need to be transmitted for the transmission of the co-infection. So although there's no data to support this at present, hopefully with the declining rates of HIV mother-to-child transmission that we're seeing, we'll also see a decline in transmission of HIV-HCV co-infection. And there's also some indications that amongst co-infected women on successful ART, rates of HCV vertical transmission may be reduced. So in terms of HCV seroprevalence in pregnant women, this slide just highlights the fact that the seroprevalence rates, for example, are quite low in Northern Europe, but much higher, 2% in Ukraine. And here we see Egypt, 8.5%. And then there was a very recent meta-analysis from sub-Saharan Africa showing 3% overall HCV seroprevalence. So when we then look at pregnant women with HIV, what is their HCV seroprevalence? Well, it really depends on the main mode of acquisition of HIV in the population. So we see here that there's relatively low rates of HCV seroprevalence in some African settings, or in places like the UK, where the large majority of HIV-positive pregnant women are from Africa, and then very much higher rates in Eastern Europe, where there's an injecting drug-using epidemic. Then moving on to the seroprevalence of HCV and HIV-positive children and adolescents. The data is quite sparse, and some of these studies really vary in size, but just to give a feeling for the fact that there's relatively low rates of seroprevalence in some settings, but in others, much higher. And you have to remember that for some of these children, they may have discordant modes of acquisition of infection. For example, they may have acquired HIV vertically, but then because of being HIV infected and in medical settings where they may be at risk of acquiring HCV iatrogenically. Within EPIC, which is a European cohort collaboration, we recently conducted an HIV-HCV co-infection study. We identified 229 young people across all the European HIV pediatric cohorts. The majority of these, as one would expect, were from Eastern Europe, and about a quarter of them had a history of AIDS. 61% had vertically acquired HCV infection, 7% iatrogenic infection, 18% were young people who injected drugs, and the remainder had an unknown mode of acquisition. But it was interesting to note, and this may be a particularly unusual situation, but there were a few young people who had acquired HIV nosocomially in Romania as young children, but then through their risk behavior acquired HCV through injecting drug use. So again, you can have this discordant mode of acquisition. And in terms of the genotypes that we found, that really was as expected given the global distribution and what we know about genotypes in Europe. And Giuseppe will be sharing some of the clinical results from that study later. So my final slide relates to growing up with vertical HCV infection, because and I haven't had time to go into natural history of hepatitis C in this presentation, but studies have shown that the development of advanced liver disease is very uncommon in children with hepatitis C, with an estimated about 2% developing cirrhosis. But as we know, the probability of liver fibrosis increases both with age and with duration of infection. And although few children are likely to experience end-stage liver disease during childhood, they are likely to be at increased risk of developing cirrhosis and HCC in early adulthood. And this is really a situation where we need more research and longer-term follow-up to really explore what the risks are in adulthood of vertically acquired or childhood-acquired hepatitis C. But in one study from Denmark, amongst adults with hepatitis C, there was a 26-fold increased risk of liver-related deaths associated with childhood-acquired HCV. So more research is definitely needed into this. So thank you for your attention, and I'll be handing over to Giuseppe.